and this was a talk today that last time we were here, we talked about topics that you all were interested in learning more about, and this was one in particular that came up, which is adult ADHD, attention deficit hyperactivity disorder, but I'll just use ADHD. Some people say ADD versus ADHD, but ADHD is still the proper term. So what I thought we'd do today was maybe just a little bit of general information about ADHD, but then I think what you're really going to like, it's going to be a lot more interesting, are some clinical vignettes. I picked 3 that I thought might be cases that you could recognize from your inpatients. And I had some questions, and we could kind of go through the cases. I think that'll be the most interesting part of the talk for you, but you can ask me questions anytime. Also, I had Neil, our pharmacist, who I don't know if you all met him before. He's a really good resource too. I had him kind of come up with a chart, which is just a 1 sheet to look at all of the ADHD medications and compare them. And we broke it down by duration of action and stimulant versus non-stimulant. And then we threw in some pricing information in there because we know that in the real world, pricing can be an issue. So we'll kind of use this and refer to this as we go through some of the vignettes, but this is something you might want to hold on to. It's a good kind of like quick reference. So, all right, so let's get started. So adult ADHD, when you hear that, what are some things that come to your mind? Like, what are your gut things that you think of in primary care? Problems?
Yes, problems. I think somebody wanted to get medication for other purposes other than what they're intended for.
Right, so the stimulant problem,
Yes.
right? People can abuse stimulants, they can sell them.
Weight loss and stuff.
They want to lose weight.
Performance enhancement.
College kids in particular. Do you see a lot of college kids here who are asking for stimulants? Maybe high school kids even? Okay. All right. So I think, unfortunately, ADHD, in adults has kind of this negative connotation with it, which is stimulants and then all the problems of stimulants. And the media has kind of perpetuated this problem because there's a lot of press about these drugs and a lot of press about the bad things that can happen with these drugs. And while we shouldn't minimize the problems associated with it, I think the important information and the positive stuff gets lost in the shuffle. So we'll talk about some problems, but I also want to focus on the disorder itself and some of the positive ways that you can treat your patients with ADHD. So first of all, I'm thinking about the diagnosis of adult ADHD. When you have someone who comes in and wants a diagnosis, what do you generally do? If someone says, I think I have ADHD, what can you as primary care do other than send them to another provider?
Start with a really good history, with behavior stuff.
Exactly. So the first thing I have down here is the clinical interview. And the clinical interview is still the most important part of diagnosis, like you're saying. And you need to ask questions not only about the current symptoms, but the history of the symptoms, right? Because you want to be able to establish some symptoms at least going back to age 12. It used to be going back to 7, and then they revised the criteria. You want to at least have something going back to 12. Now that doesn't have to be, I failed out of school, or the teachers kicked me out of class. It could be more subtle, but you do want to see something going back into like middle school or high school years. So the clinical interview is still the most important part of your diagnosis. And you want to understand really 3 main things. What you were saying, the history of ADHD symptoms. So when did they start? What do they look like? How they persisted over your life? But you also want to know, how do they impact your current functioning? So with ADHD, some people have minimum impact on their lives. If their life is pretty simple, straightforward, people take care of them, things for them, they might not have a lot of trouble. But if there's someone who's working full-time and married and they have 3 kids and they have financial problems and they have their parents having problems, and once their life gets more complicated, the symptoms might have a greater impact on their life. So you might see people who've gotten through their whole lives, and now they're 30 years old, 40 years old even, and all of a sudden the same symptoms now are overwhelming. But they didn't used to be a problem back in high school or college. So that's kind of, I think a lot of people forget that. Like, even though you had the symptoms, maybe they just never caused you problems until your life got really complicated. So that's really important. And then the third main thing about the clinical interview that I really want to emphasize is rule out other causes of attention problems. So you all do primary care. What are some medical things that could impair attention?
Depression, hypothyroidism, caffeine usage.
Even low blood sugar. So there's a number of purely medical things that could impact your thoughts, right? Your attention and focus. So you want to make sure that you're ruling out other possible causes of ADHD before you jump to that diagnosis. Okay, so that's the first part, the clinical interview. Second part is some sort of rating scale. So I don't know if you've seen, especially with kids, a lot of times they'll have like a Vanderbilt rating scale. Have you run across any of those? Like where the teachers will fill out a form, like circling the degree of impairment in school?
No.
Okay. So this might be a new thing to think about for your ADHD patients is rating scales. These are still relatively subjective because it's a person, giving their report, but you can get them from parents, teachers. If it's an adult, you can get it from a spouse or a sibling or somebody who knows that patient well. And the reason that's really important to get a rating scale is patient self-report in ADHD is notoriously bad. And there's actually a lot of studies to show that they're not reliable historians of their symptoms. So this may be something we can talk about more, like in terms of how do you pick a rating scale, how do you use it. I gave some examples here. Children normally use the Vanderbilt one because that's given to their teachers. But in adults, there's some different choices. There's a real short one, which is a good screen, called the ASRS, but it's not very specific. If you want a more specific one, there's one here I wrote, the BDEFS, which is much longer, but it's much more specific. So we could talk more about some of the different rating scales. And of course, in a busy primary care setting, you got to balance time, and energy with these rating scales. But if you do them, they're going to save you a lot of headaches down the road. So that's the second part. Now the third part, I think we mentioned just briefly, Dr. Shi and I had mentioned, there are objective tests of attention. And they're either computer-based tests that you can sit at a computer and do tasks of attention that give you a quantitative objective score, or you've probably seen people go out and get neuropsychological testing done, where it's like a pen and paper test with a neuropsychologist, and sometimes it's a 2 or 3 day battery of tests. It's pretty long, it's pretty complicated, and it's pretty expensive. But a lot of people will refer out for that. Have you ever seen that at all? Any of your patients brought that into you? Yeah. Okay. So you're probably getting people more walking in the door like, I think I have ADHD, give me some stimulants.
Exactly.
Okay. So these are the 3 parts of, if you wanted a complete ADHD, you really should have these 3 components. And it's something to think about, like, is your practice set up to get all 3 components or not? And you may feel like it's not something you're set up to do. But to have a real complete eval, you really want those 3 components. Okay. So I wrote the DSM-5 criteria. I don't want to spend a lot of time on that because it's kind of boring. I think the main takeaway for this is that these symptoms in adults look different than the symptoms in kids. So for example, kids might have more trouble with schoolwork, whereas adults might have more trouble at home trying to remember to do different chores and multitasking, and they might be always late and missing appointments, procrastinating stuff around the house because they're putting all their energy into their job and they're kind of just functioning at the job, but then their house is a disaster. So in adults, it looks a little different than kids. So I did include these here. These are the diagnostic criteria. And again, there's multiple symptoms. They fall into 2 main groups with this inattention and hyperactivity and impulsivity. And another takeaway here is that in adults, most people do not appear hyperactive with ADHD. I think that's another common misperception, like, well, he's sitting in his chair quietly, he can't have ADHD because he's not hyperactive and running around the room. Most adults have an internal sense of restlessness rather than an external hyperactivity because society has trained them that they have to sit in their chair. But you might notice them being really fidgety, tapping their leg, playing with their hands, and they might internally feel very, very restless even though you don't see it in the room. Another important thing is adults tend to have more problems with the impulsivity than hyperactivity. So impulsivity in adults, what does that look like? The big questions you can ask to get an impulsivity in adults are driving. What's your driving record? Do you drive too fast? Do you get a lot of speeding tickets? Do you have a lot of fender benders? That's a really good way for it to show up, Michael.
Hey, how are you?
Good. Another way it shows up in adults is spending. And a question you could ask is, when you get a lot of money, do you tend to just spend it all right away, regardless of whether you should or not? Do you have trouble managing your money? Impulsivity sometimes in men shows up as fighting, like bar fights, getting really like violent outbursts of screaming at people at work, really explosive outbursts. Impulsivity causes most of the problems of adult ADHD. So these patients have terrible driving records, points on their license, legal fees. They've lost jobs because they blew up at the boss. They've been divorced 3 times because they couldn't get along with their spouse. They maybe have substance abuse problems because they're very impulsive. And the impulsivity is really where the adults have more problems.
Sounds like there's a little bit of overlap. And some of the things you mentioned sounds a little bit like bipolar disorder
Yes.
too.
Yes.
You're exactly correct. There is a core feature of impulsivity in the manic phase of bipolar disorder. So the key difference here would be that bipolar, you're looking for a cyclical pattern of highs and lows, whereas in ADHD, you're looking at persistent impulsivity regardless of mood, regardless of time. So it's a much more consistent history from someone with ADHD. Like, yeah, I'm always running my mouth off. As a kid, I used to talk in class all the time. I interrupt people all the time. No one can get a word in edgewise. People say I'm not listening to them.
Don't hate y'all.
So yes, you're right. The impulsivity does have a big overlap. But the key for bipolar would be, it would be during the manic phase of bipolar that you're having symptoms, not during the depressive phase and not during a more neutral mood. So that's where that history that you mentioned, getting that time course is really important. So I'll let you look at these. The third thing that's really important to note in terms of meeting criteria for adult ADHD, again, you have to rule out other things. So like, is someone just having ADHD symptoms because they're bipolar and they're manic? Is someone having ADHD symptoms because they're hyperthyroid and they're out of control? Is someone having ADHD because they're doing cocaine? You know,
Right.
there are like a lot of other reasons that you could have those symptoms other than ADHD. So again, kind of that's the pearl to take away. Like, you need to rule out those other things first. And I would actually, especially since you're in this setting, just get labs on people, especially for thyroid is a big one. Get detoxes, make sure that there's not like something else going on. Okay, so this is kind of the boring part. Any questions on that before we start talking a little more interesting treatment options and vignettes? No? Okay. So treatment of ADHD, the first thing that came to Dr. Shia's mind was stimulants, right? And that's what gets all the press. That's what people come in the door thinking they're going to get from you. That's what their friends are taking. That's what their kids are taking. That's what they're thinking about. Stimulants are only part of the picture. And this is, I think, important for you to understand. And I think will save you some headaches as well. Once you understand the other treatment options, you won't always feel like you have to jump to a stimulant. So first of all, there are non-medication treatments for ADHD. Most people don't know that. So I put some here. Self-help treatments, including sleep scheduling. Most people with ADHD have a shifted sleep schedule, and they really have to learn how to manage their sleep, or they're going to kind of always come in saying, I have insomnia. Daily exercise, again, shows to have a lot of benefit for people with ADHD. Learning strategies for time management and organization. That's something that medication does not typically treat. So if someone comes into you, I'm a mess, I'm scattered, I can't manage my time, I'm always late, that may not get better on medication. They may have to learn other ways to cope with that. Some good things about self-help: it's cheap, it's convenient, some symptoms do better, like the time management, organization. The cons, most adults have trouble already with consistency and self-monitoring, so for them to go out and do self-help on their own, sometimes you're setting them up to fail. So if someone's really severe ADHD symptoms and you're like, okay, just go out and set up a schedule for yourself, the likelihood of that happening is, you know, very, very low. I don't know, coaching, have you ever heard of coaches? These are people typically for school kids, but they can be for adults too. Coach is kind of like a coach. It's someone to help you with your motivation, keep you on track, accountability. They're not a therapist, they're not a doctor, they're like a coach. So someone with mild ADHD symptoms who just needs some external help staying on top of things, a coach could be a very good option. Coaches can work via email, texting. It doesn't have to be a giant time and money commitment. So it's something to think about. Psychotherapy can certainly help. People who have depression and anxiety along with their adult ADHD, which is like maybe 30 to 40% of them, do well with psychotherapy because untreated ADHD, as you get to be older, it leads to a life of frustration, right? Why can't I do anything right? What's wrong with me? I know I'm smart. Why can't I do well? Why am I getting fired all the time? So a lot of anxiety and depression. When you treat the ADHD, sometimes that gets better without medication for depression and anxiety, just by treating the ADHD. Cognitive behavior therapy is kind of considered the mainstay of psychotherapy for ADHD. Supplements, dietary changes, this gets a lot of media press. You've probably seen, or patients come into you saying, like, I'm on fatty acids, or I'm on, you know, gluten-free diet, or I'm on no sugar diet. And the evidence for that, I would say, is pretty mixed, so I wouldn't recommend it to everyone at this point. You know, gluten-free diet maybe helps certain people. It seems like a subset of ADHD kids may be related to gluten allergies, but I think the evidence isn't really strong enough to just say across the board you should do this. And that's my opinion.
Can you go back to the coaching? Now, I have seen some of my friends, they said like they're life coaching. Life coach, like, is that the kind of the coaching you're talking about? People who like advertise life coaching services?
It could be, but that person has to have a specific understanding of ADHD.
Yeah, that's what goes to my next question is, do they actually have any specific training in coaching for ADHD, or is it kind of like the Wild West with coaches?
It's a little bit the Wild West. So short acting, moderate acting, long acting. So short acting's like 4 to 6 hours, moderate's like 6 to 8, and then long acting is more like 12. And as we go through the vignettes, I think it'll make sense why to think about it that way. But I wouldn't worry about the class as much as I would worry about the duration of action. Pros of stimulants, limited action time, so you could take it, it's in your body, it's out of your body. You don't have to take it every day for it to work. You can tailor it to your school or work schedule, like I just want to be taking medicine while I'm in school and then I go home, I don't want to be on it anymore. It's relatively inexpensive. Some stimulants are more than others, but as a whole they're relatively inexpensive. Obviously you know about the downsides, right, which is what you're talking about. Abuse, diversion, which is when people sell their medications. The crash is a big downside. Have you had patients talk to you about crashing?
I live it.
What do they say?
No, I'm just saying. No, I mean that. You know, if, I mean, I'm on Adderall myself, and
what's the crash like?
It really is. It's in addition to the fact that you. I mean, it's more than just being tired. It's literally feeling like your head's in a vice and you just can't think. And it really, you know, just to the point of like right about now. No, I'm kidding. No, but to the point that where it's almost. Who here has had vivid memories of when you were drunk in college? Come on, somebody's got to be honest besides me. But you remember those moments when you would literally be trying to think that if you could just think, you could figure this out. There was some problem. Trust me, but the next day it was a complete insanity. But if you could just think it through, it would all fix itself. And that's what the crash is like.
So I have a question about the crash. So then, say if Michael's having crashes every day, would then we want to switch to 12 hour or something?
Right. Sometimes.
Sometimes that helps. Sometimes it doesn't.
Sometimes that, right? Because sometimes it did. Honestly, now this is what here's where there is. I can give you some real world. It depends on what's going on in that person's life. It depends on their pattern of when they need to effectively focus on in a day. You know, some people, like for example, students that are in college, a lot of times there might be this block of time where they have to focus. But there are people who who actually have a split mental shift, and there's actually a break of time in the middle of the day where it's not as important. And so, you know, that 12-hour, what ends up happening, first of all, 12-hour really ends up being 8.5. Okay, let me say that. But so I mean, to where all of a sudden you really at that moment when you really need it, it's not there. But I would say though, crashes happen more on your complete off days. A lot of times you can even take a subtherapeutic dose to avoid a crash. And as a matter of fact, when I'm educating other people, and I learned this the hard way, I actually don't go for complete symptom relief. That's one of the things. That's one of my teaching points to them is that because the side effects, the downsides of stimulants are pretty harsh. I try to tell them that you're trying to find a happy medium between being focused and at the same time not being a butthole. Because if you're really focused, it can.
People can get very antisocial.
They
get too narrow focus where they're not paying attention to their families.
Right, and you know, if things that are irritants become hyper irritants and things like that.
So there are significant.
I'm sorry, that was more than I intended.
No, and to have it firsthand is really helpful because it's true. You know, and I think people hear this from patients and sometimes they blow it off like they're exaggerating. But I think it's really the experience is pretty significant for them of a crash. Right. So it's something to think about. And we can talk about some strategies for crashing too. Stimulants are controlled substances. You know all the headaches about that. I won't even go into them because you know them all. You can develop tolerance. So that's your body gets used to it. You have to go up on the dose. And now all of a sudden you're at Adderall XR 30 and you're like, what do I do? Do I keep going? I'm not comfortable. Do I send them to a psychiatrist? Like, what can I do? Right. That's a big issue. One thing I want to talk today about is non-stimulant medications because this is not talked about in the media. This is not talked about, and this is really important for you to know because it can really save you headaches. There are non-stimulant FDA-approved medications for ADHD. Most of the people who treat kids are more familiar with them than the people who do it in adults. This includes Strattera, atomoxetine, which is I don't know, it's not even a really newer medication at this point. It's been around for a while. Yeah. Guanfacine is the generic. It's a twice-a-day dosing guanfacine, or the long-acting Intunib. It's the same thing, but once a day. You may not know that Wellbutrin is not FDA approved, but it is considered a second-line treatment for ADHD. Bupropion, you know, that's pretty cheap. Clonidine, that's my go-to sleep medication for ADHD. You may have used it for someone with blood pressure issues, or maybe a patient who's getting some detox issues from substances. That's a great sleep med for ADHD. So the pros of non-stimulants, you can treat comorbid problems. You can hit anxiety and ADHD with Strattera. You got two birds with one stone. You can hit depression, anxiety, and ADHD with Wellbutrin. You can do one medicine to target three problems. You don't have the abuse potential issues. You don't have the crash. You're looking at a much more steady state of medication in the body, so you're not going like this, up, down, up, down, up, down. It's much steadier feeling for the patient. Not a controlled substance. You can e-prescribe them. They're just normal. You don't have to go through all the headaches. The cons are they're relatively expensive. Now, not all of them, but the Strattera and Intunib are relatively expensive out of pocket. Most of them need to be taken every day. So for someone with ADHD, right, they're going to miss some doses. Less intense effect on attention and focus. So that someone who's used to taking a stimulant and used to that feeling is not going to feel that way with a non-stimulant. You have to warn them, like, this is going to feel different. You're not going to feel that intense zone that you felt with your stimulant. This is going to feel much steadier.
I call it more like a sunrise. It's just all of a sudden, over time.
It's kind of slowly. That's nice. So I think this is something as a practice to really think about because, like I said, I think you'll save yourself a lot of headache if you get comfortable with these meds. There's not too many of them to get comfortable with.
So with clonidine, and so it's dosed in BID or TID. Is there any concern about rebound hypertension with that if it's being used in someone who's not hypertensive?
There's been some concern, especially in kids who take clonidine of the rebound. Normally in adults, I just do a low dose, like a 0.1 milligram at night, not during the day, because they get too sleepy on it.
So the clonidine here, you said, is more for the sleep, not for the attention.
There is Cat-Vay, which I didn't write down there. That's the brand name once a day dose for clonidine.
All right.
But that's kind of my go-to sleep. Someone has that sleep problem. It seems like it increases the amount of time that people with ADHD spend in deep stages of sleep, so they feel more rested upon awakening.
Okay.
Okay. And so then just some pearls. We've kind of already touched on some of these before we get to the vignettes. One is get corroborative information. Try not to rely on the clinical interview alone. This is very, very hard in primary care because you just are limited on time and resources and people's willingness for you to call others. But again, I think you save yourself a lot of headache down the road if you get some corroborative, because it may not be ADHD. You may call mom, and mom may say, oh yeah, none of these symptoms ever existed. He just started having these problems when he was 35 and he got married.
Right.
You know, so you may save yourself some headaches if you get some corroborative. 2, we talked about rule out the other causes of ADHD symptoms, thyroid, medical issues, always think about those. If it's comorbid depression, anxiety, consider a non-stimulant first before the stimulant. You may be able to kill 2 birds with 1 stone. If they have a history of substance abuse, you definitely should consider a non-stimulant first. At least try 1 or 2 of them, and then you can say, we tried them, they didn't work, now I'm going to prescribe a stimulant. That will, I think, protect you as a doctor, and you'll feel more comfortable. Again, protect yourself. If you are prescribing stimulants, you probably already know this, avoid early fills on meds. If someone in the office can check the control database. I don't know if you have a system for that already.
Quite often.
Yeah, just use that system you have. When selecting a stimulant, if you are going to go with a stimulant, think about what you talked about, the duration of action. What is the person's life? Are they a student? Are they working 2 jobs?
Right.
Are they having a lot of trouble at home and they need coverage at home? Like, what's their life telling you? And that will guide you to pick one of these groups.
And I'm sorry, one more piece on that is, what do they want to do on their days off?
Right.
Because if they really do, if they really don't want to take the medicine on their days off, that goes back to that whole subtherapeutic dosing. The lower the dose, the softer the crash. And so.
But if they want to reorganize their entire house with their wife over the weekend, you may need medication.
Right.
Then you're going to get into a fight with your wife because you're not able to be organized enough over the weekend.
Absolutely.
You're laughing. I've heard this story a lot.
Every once in a while I'm like, what? Do you want me to medicate?
Right.
Do you need me to focus?
Right.
I have questions about 2 medicines in particular. And the first is Strattera.
Okay.
And my experience with Strattera is when I have used it, even I'll start at the very lowest dose. The patients I've come back in a few weeks, and they just said they just couldn't. And I don't know if I should believe them. They said 10 milligrams. They said I couldn't sleep for 2 days.
I would start high.
Let's get our attention up a little bit.
It does.
And I'm wondering if in this situation it shouldn't really raise my attention as much because they're going from something more abusable to something less abusable.
Right, and the fact that it's a longer duration of action, some substance abuse literature, people think that the longer the duration, the less abuse potential. So like with your benzos, an Ativan's going to have a higher abuse potential than a Klonopin. Now some people would disagree with that, but I wouldn't worry too much about Vyvanse. It's certainly, of all of these, probably the least abusable.
Okay.
I think they advertised really well, and they got a lot of kids on it, so they're probably hearing about it from people whose kids are on it. That would be my guess.
Okay.
But Strattera, I would start at, if someone's real sensitive to medicine, you could start them at 18 or 25, but if they're, healthy otherwise, I would start them at a 40, and then if they run into GI problems, you're going to have to stop it. But you can push it easily up to 80 in adult. I think most people have her either on 40 or 80.
So you haven't noticed it, because I tried Strattera first, and had terrible anticholinergic type stuff. I mean, I didn't crap for a week, and that was the deal breaker. That was the deal. Whatever. I got to deal with food now.
I've had some people get moody on it.
Oh yeah. Now, and actually, I was prepared for that because my primary was very good. He said, I want you to give it a month, even if you feel like you want to get into fights for the first 2 or 3 weeks. give it a month.
It does take a week or two to build up, so you have to tell patients, we're in this for 2 weeks at least, if we're going to try it. And definitely, it's not for everybody, but I think, again, especially like your substance abuse patient or someone you're worried about, it's definitely worth the trial of it, even if they fail the trial. Let's see, a few things. Most ADHD patients forget to take their second dose of medication. Once a day dosing tends to improve adherence, same for other meds, but particularly for them.
I call it, it's terrible to have to remember to take a medicine that helps you remember.
Exactly. We talked about clonidine. If they have insomnia, consider clonidine. If a lot of people have a shifted sleep schedule where they fall asleep and wake up 2 hours later than everyone else, consider using melatonin and a daylight in the morning. That will simulate the body's natural circadian rhythms. And melatonin is very easy to take and benign, so you may be able to shift them without going to Ambien or without any of that other stuff. Again, corroborative information from when you ask somebody, how are you feeling, how's the medication working, if you can get a corroborative from someone, say, oh yeah, they're much better, that's going to save you a lot of headache down the road.
I do the same thing for depression. I ask them to bring their spouse in.
If you can do it, I think it's worth it. I know it's hard.
Yeah, but if you can, it's useful.
And then from a practice management point of view, they tend to forget more than other people. So frequent reminders, strategy for missing visits, and refill requests. You probably already have talked about this as a group, that they're going to forget their meds, they're going to lose their prescriptions, they're going to miss their appointments. What's your strategy? Just have a strategy in place so that you know how to handle that, because that's going to happen a lot. Okay, we have a little more time. So what's the time frame for you all? When do you have to go back to the patient?
I think their first schedule was at like 1:45.
Oh, so we have some time. Okay,
Yeah.
good. Okay, well then I won't rush. Before we go forward, what any other questions from you all? Meds or anything?
I apologize for any part I might have missed before I got up here, but I mean, I guess for lack of better terms, I probably have a little bit of an ADHD radar, and can to a certain degree have a healthy bit of skepticism when someone comes in out of the blue and claims. But what would you consider some of the marquee disclaimers? I mean, you're out of consideration. How about that? You're not even. You know what?
For ADHD.
Yeah, for ADHD. You know what? It's maybe you tell a good story, but you just.
I think anyone who's actively using drugs,
Right,
you
course.
can't diagnose
Not
until
anything,
you
right.
get them at least sobered up from
Right.
at least cocaine and opiates.
Okay.
Maybe less so for pot, but definitely cocaine and opiates, you have to be suspicious.
Right. Okay.
Anyone that had a sudden onset of symptoms.
Right. Okay. Cool.
And again, this is a little tricky because sometimes maybe they had symptoms, but they didn't cause them problems until
A
now.
stressor
But
event.
if they truly had zero symptoms until like last week,
Right.
I
You
think
need to
that
have a
should
healthy
raise a red
skepticism
flag.
of that, right?
If they don't want to do testing, if you say, I'd like you to do this, or I'd like you to do this rating scale, not, oh, I'll take it home and then I forgot to bring it back to you, but like, I don't want to do any of that stuff, I think that's suspicious.
Okay.
One of the nice things about the computer test is if somebody tries to fake it, you can kind of see like they just make so many wild errors. It seems obvious they're trying to.
2 + 2 is 5. Right.
Right, you can kind of, that's one of the nice things about the computer testing and the neuropsych testing. I think if someone comes in demanding a certain medication, I don't know, I mean, sometimes it might be legit, sometimes it might not be. I always pull up the database on everyone, especially, I'm sure, for a first visit.
Absolutely.
It's a good policy. Anyone who's coming in with an ADHD complaint, where did they get meds from? If they gotten 5 stimulant prescriptions in the last month, that's obviously going to be a red flag. But I said sometimes people have this perception like someone will walk in your room and you expect them to be bouncing off the walls or talking a mile a minute, and that means they have ADHD, and it doesn't always look like that, especially women.
I was going to say, because more.
Can be much more inattentive, daydreamy, kind of. They don't look like that, so you can't rely on just what they look like sitting with you in the room.
Are there certain, you have to have these symptoms or you don't? Because it seems like a lot of them are could apply to a lot of people that may not necessarily actually have ADHD. So what's kind of like, what do you have to see, I guess?
Well, it has to, according to DSM, you have to meet the inattentiveness symptoms. You don't have to have the hyperactive impulsive symptoms, but you do have to have the inattentive symptoms. They have to go back in time to age 12.
And does it have to be like super severe, or?
I think personally, ADHD is somewhat of a spectrum issue. I think someone can have more mild symptoms and someone can have more severe symptoms. So I don't think it's totally black and white. But you're really looking for how it's affecting, like what's it affecting their functioning.
Okay, so that's like the main decider.
And you may rarely have a patient on a stimulant that doesn't have ADHD. So if you have certain types of depression, that they're really a lethargic depression, sometimes, rarely, you might use stimulants for something else.
And this is not very scientific, but to be honest with you, if we don't travel down any rabbit trails while getting the story, you know what I'm saying? If we can't, especially if it's two ADDs in a room trying to talk to each other, if we can't pull each other in a bunch of useless directions, I'm a little suspicious of you, because I know I'm.
Now you might, if you notice someone that it really gives you a great ADHD story, but they just seem like really calm and linear, you might ask them how much coffee they had.
Right.
Because some people medicate with coffee and they'll drink like a whole pot of coffee.
Right.
I tell this is one of my favorite stories. I have a patient with ADHD who didn't get diagnosed until he was in his late 40s. And his wife told me that one day he was the best he had ever been, and she found out he had eaten a bag of chocolate-covered coffee beans because he didn't know what they were. Yeah. He ate a whole bag of them. And she said he was totally calm and mellow all day long. So people can self-medicate with caffeine. Most ADHD people mellow out and calm down on caffeine. So you might want to ask them how much coffee do you drink or how much caffeine do you drink, because they might be self-medicating.
I found out when I tried penteramine to lose weight.
And how to
And for the first time ever, I was like, wow. I mean, I would be able to, quit throwing the ball between the outside window and the closet, the blue ball. And they're upstairs,
Or they're self-medicating with other kind of stimulants, like in the energy. There's so many things in the drinks now, I don't even keep up with them.
I know.
But that's something to consider. You could have someone, or you might have someone really high functioning who could hold it together for 15 minutes.
That's true.
But then they're all over the place, if you need them for an hour.
Right.
And they're high functioning people. There are doctors, there are lawyers, there are, all sorts of CEOs. I mean, there are people who are really high functioning. They can hold it together, but they still, for them, have symptoms that are problematic for them.
That's what I was talking about.
I know.
All right, good. Well, let's go forward. Let's talk about some of these vignettes, because I tried to pick some I felt would sound like familiar to you as people that maybe walk in your door. So I'm going to read the vignette, and then I'm going to ask the questions, and I really want to try to avoid giving answers. I want to see what you guys come up with as answers as a group. Okay, so number 1, you have a new patient appointment for a 19-year-old male college student. He tells you he was diagnosed with ADHD as a child, and he has been taking the same stimulant medication for many years. He wants to continue with this medication, but he's not sure if he needs to increase the dose because, quote, it doesn't seem to work like it did before, unquote. He also has a recent history of binge drinking and a few minor driving accidents since he started college. His sleep is erratic. He often stays up all night and then oversleeps the next morning and misses his class. Does this sound like someone that maybe walked in your door?
Mm-hmm.
Okay, so number 1, do you give him a diagnostic workup? He said he had it as a kid. He's been taking meds for years. Do you need to diagnose him?
Mm-hmm.
What do you think?
I think you need to cooperate.
Okay. So what would you do?
Certainly, if he's been on it that long, somebody's got records of treating him. It's not as good. I find that to a certain degree, the workup isn't a lot of times any more detailed when they were peds than we do as adults. But still, it gives you. He's convinced someone else before that he has ADHD. Definitely, I always give basic lab work because I like to. I just cover with the patient. I want to make sure that whatever I'm going to give to you is not going to harm you.
Mm-hmm. So you might ask for old records.
Right. Might do a baseline drug screen. Being that he's on a controlled medication, I might actually just do a qualitative screen rather than our diagnostic screens that we use for our controlled medication patients, but at least get an idea of what's floating around in the pee. Mm-hmm. But other than that, your chemistry and your thyroid before I really went any further.
What if he says to you, I was a kid and my pediatrician thought I had ADHD, so he just gave me some meds, but I never did any testing.
Right.
What would you do then?
I don't necessarily dismiss dismiss it right there either. And then I go back, then it becomes part of that's more of my example. You know, what do I think he demonstrates things that go along with it? Because the truth of the matter is, the testing for ADHD is lazy. It's very lazy. It's pediatric or adult otherwise. I mean, honestly, if you can answer the question, if you can answer your DSM questions correctly, you know, if you study for the test, you're good. You're golden as far as your exam piece of it. So it's disconcerting, but it's not dismissing.
I think that's a great answer. And you're saying maybe you would delve deeper into the history.
Right.
If he walked in the door with like a complete neuropsych workup and history and
that almost puts a red flag up for me right there. Yeah, exactly. If he's got all that, and I'm like, no, I don't know.
you have that, you're too much together.
Yeah, that's right. You really planned for this one. But seriously, if he'd actually had you know, the full like a full psychiatric evaluation where he was observed in his behavior,
You might not delve as deep.
I wouldn't delve as deep. That's correct. 'Cause, I mean, there are some things that you can take at face value. Someone transitioning from pediatrics has been on Adderall, 15 milligrams, you know, for the past 5 years, and now they're an older adolescent. I'm not going to necessarily say, you know what, you're better off without it. You know, and let's see how you do. You know, because you know, they're at a point in their life where I'd almost say that it's probably a lesser evil to continue the medicine in this short term than it is to just stop it.
And what are you all? How many kids with ADHD you think have it into adulthood? What have you heard? What's the percentage?
I haven't seen anybody lose it. I'll be honest with you. Now they may stop their medicine, but I've not seen anybody grow out of ADHD.
Anyone else have any numbers
That's my opinion.
thrown around? No. Used to be thought that people grew out of it.
Right.
Then it used to be thought, well, some people grow out of it 50-50. Now we're looking at probably at least 70, 80% people have it in adulthood. So most people do not grow out of it. So the fact that he was as a kid and now he's 19, that makes sense.
Yeah.
And he'll be 25 and he'll still probably have it.
Right.
And he'll be 65 and he'll still probably have it. Okay, great. Would you give him a stimulant today? Would you worry about it? What would you all do?
Well, I would say as long as his drug screen is clean, and I have requested old records, I wouldn't have a problem with continuing him on his current dose. I wouldn't make any changes until, and I would have him have close follow-up, let's say, in a couple of weeks. Should expect the records to be back by then.
Great. I like that you added the follow-up because that's part of this, right? Would you give him 90 days?
Oh, never. No.
Never.
No.
Okay.
And I'd also I'd be having a conversation that the reason why his dose doesn't work like it used to is because he's adding a CNS depressant on it in heavy amounts. You know, you take a stimulant and a depressant, they just don't go well together.
Right. So kind of moving right along, does he have substance abuse? He's in college, he's binge drinking on the weekends.
Yeah.
Is this substance abuse?
It's abuse. It's not necessarily addiction, but it is abuse.
Okay. So what would you tell him about using a stimulant and drinking? He's college, he wants to have a good time. What would you tell him?
Well, have a good time to get some education, that everybody knows about it.
So talk to him about how alcohol affects ADHD.
Right.
What's your number one worry in someone with ADHD drinking? It's in the vignette, that's my clue.
The accident? No.
Yeah.
Okay.
The car.
Yeah.
Oh, okay, because all of a sudden
They're already at a very high risk of car crashes.
right.
Now
And
you
now
put
they're
alcohol.
awake. And now they're awake, but inhibited.
So part of the
impaired.
education, I think a good way to get people to understand is, look, with ADHD, you're going to have a higher risk of car crashes. You're drinking on top of that. You already had a few small crashes. You're really putting yourself at risk to have a DUI or to hurt yourself. And maybe that's an angle you could talk about in your psychoeducation, because they are at very high risk, especially at this age.
I also, because I have had a couple people that have been similar. Yeah, I also talk about the eye on the prize. If the prize is that you need this medication to help you function, blah blah blah, then you need to stop doing things that make it difficult for either the medication to work or me to even prescribe. Because I'm not going to put if I know that you're in an abusive pattern, even if I think you need the medicine, I'm not going to be inclined to prescribe. And that's the conversation I have with them. I mean, the does that keep, but it does cause them to, in my experience, it has caused them to think twice before going to this level on the binging, you know.
Bring down the level.
Yeah,
binge,
we start doing harm reduction
Exactly.
type stuff.
So, you know,
Can you stop at 4 drinks when you're getting together with your friends?
can you not drive?
Can you not
Can
drive?
you commit to me that you're
Right.
not going to drive?
Exactly.
Things that can do harm reduction. I like that. That's a good one. So we would kind of agree this is maybe abuse of alcohol doesn't really meet like a dependency level from what we're hearing, but something to tuck away in your mind, because most people, when they tell you 3 drinks, what does that mean?
6. Yeah.
More.
Right.
Yeah. I normally
Oh.
multiply by 3. So if a college student tells you I had 3 beers, I would think it's more
Better
than
than
6. Yeah. So tuck that away in your mind for this kid, because he may have trouble down the road with this substance issue. Here's a question. Would the stimulant medication make his driving better or worse?
In relation to combining it with alcohol,
Or on its own?
or on its own? On its own, it'll make it better.
There's a ton of recent evidence on driving while taking your medicine and off your medication. Much, much improved driving, less dangerous, less wrecks on medication. If no other reason than to take medication, that may be one of the reasons for people to take medication.
This is.
parking.
I don't take my medicine until I get in the door.
So you've parked.
It was just one particular bad morning that was especially poignant, yes.
All right, good. How do you decide whether or not you're going to increase it? Because he's telling you, I don't think it's working that well. Should you increase it? Should you switch it to something else? How would you make that decision? Again, assuming you can't refer out and you're going to have to handle this yourself, how would you make that choice?
I would say his old records would have a big bearing. I mean, like if his, let's say his primary doctor just had increased it 6 months ago, and he's asking for an increase, I would say, I don't think so. But if you saw that he was on his current dose, say for the last 4 years, and it hasn't been increased, I would be at least inclined to consider a therapeutic trial. Of course, the other thought is consider maybe a different medicine, but I wouldn't really know what to go to. I mean, would you go to a longer-acting medicine, or? I mean,
Well, let's say I didn't say specifically what he's taking here. Let's say he's taking Adderall, short-acting Adderall 15. Would you go up? Would you go to Adderall XR? How would you decide?
I guess I would really need to know what his daily routine is like.
Yeah.
I don't think there's enough information to decide in here.
Right.
What's your class schedule? When do you have to get up? When do you have to do your work? When do you have to do presentation? When are you driving?
And
When do you need it to be working?
and I'm even more inclined, just from personal experience. I've been on both, and Adderall IR. I mean, just for me, hits you like a ton of bricks. I mean, it gets in your system, 30 minutes, and so that's good on the focus side of it. But on the side effect side of it, that's also disproportionately high too. So a lot of times I consider that. My point is, let's say that they're still short acting. My point is, I would consider myself would consider multiple dosing before I would consider increasing the amount at one time, or long acting. I'm saying I would advocate
More hours.
Yeah, more hours of coverage, rather than a higher dose at the beginning, because it does peter somewhat consistently. In other words, 15 milligrams does last shorter than 20 milligrams. So in that way, the half-life and all that stuff is fairly consistent. But the side effects are just stronger, so much stronger the higher the dose you go. That for me, whenever I advise others, that's when I start going. We're getting a lot at one time here.
Now, another question you could ask him is when he says it doesn't work, what do you mean? Oh, well, it works great when I take it, but then it wears off after 4 hours.
Right, exactly.
Or, well, it just doesn't work at all anymore. I take it and it just never does anything. Those are different. If it's wearing off, you might do longer acting, you might increase the dose, but if it's just not working at all,
Right.
you might need a different strategy.
We want to know how long he's been without the medication, and what caused him to think that he needs it again.
That's right. That's fantastic. Yeah.
Maybe he decided to take himself off in summer because he was goofing off and having a great time, but now he's back at school and things, he needs it again. What if he's taking Adderall XR 30? Would you go up on that? Would you switch? Would you augment by adding a non-stimulant?
That's something I've never done. That you make an interesting point.
So 30 is kind of your upper limit, right?
Yeah.
Your FDA upper limit, so you're probably not comfortable going much above that. He says, well, Adderall still works pretty great, it just doesn't work the way it used to. Oh, and by the way, I tried Concert, I tried Ritalin, I tried every other stimulant under the sun. Adderall is the only one that works for me, it's just not having the same effect. Well, would you maybe think about augmenting at that time? That might be something to think about.
It is, yeah, I mean, I've seen some patients, they'll be on Adderall XR, and then they'll have a few limited supply of just immediate release Adderall.
Intuniv is a great add-on. So you'll see a lot of kids who've been on Vyvanse plus Intuniv together. Intuniv, this is just my opinion, this is not like a published finding, is particularly good with impulsivity. So people who are really impulsive, it's a great add-on. It's pretty easy to take. So think in that patient who's maxed out on their stimulant, has tried everything else, you might want to think about augmenting, even though that's 2 pills.
Right.
Which makes it harder. You might want to think about that.
But most of the time, though, when you mentioned the 2 pills, though, but most of the time, if they're driving the boat, there is a motivational trigger in there that will allow them to be more compliant anyway.
Right.
Because
and if you take them at the same time,
if compliance is going to be an issue, compliance is going to be an issue. Right.
Okay. Final question on this one. What about insomnia? Does he have insomnia, first of all? And if he does, what do you do? So he's a college student, staying up all night to study, and then oversleeping. Is that insomnia? What do you think?
I think it's
never had the problem before until college.
Right. I think it's the alcohol. In that, alcohol may put you to sleep, but it won't let you stay asleep. And so my first thought is it's not intrinsic insomnia, or it's not. I wouldn't even blame the medicine on it at this point, at this juncture.
Right. So what would you do? You would talk to him about alcohol.
Right.
And sleep.
I was just say, I would just probably think it was college culture, the all-nighter.
There's that too. Exactly.
Right, so that's a difficult talk to have. Well, all your friends are staying up late to do this, but that may not be helping you. You may have to go back to your room and go to bed before everyone else. What's that going to be like? That's maybe not going to be so much fun, but you may need it to function. For a 19-year-old, that can be real hard. All right, any more thoughts on this vignette? And we'll go on to the next one. No? Okay. Number 2, I think this is one you probably hear a lot. This is my guess. So number 2, you have been seeing a 35-year-old female for routine primary care visits for years. She's been having some marital problems. She's in couples counseling, and the therapist says she might have adult ADHD. She's had some mild depression in the context of marital problems for many years, and she did have some postpartum depression and anxiety since the birth of her 3rd child. Now she tells you, quote, I often feel overwhelmed and I worry I can't handle all this. She started sertraline 100 milligrams daily with postpartum depression, and this has helped somewhat, but she still feels worried and overwhelmed. She's now thinking that ADHD medication could help her manage her household better, and this would improve her marriage. She doesn't want to go to a therapist because she's already paying for the couple's counseling. Does this one sounding a little bit maybe familiar?
Mm-hmm.
Does she have adult ADHD, and how do you figure it out?
I don't think she does.
So why would you think maybe this case would not? What are some indicators here that maybe she does not have adult ADHD?
Timing of her symptoms.
Mm-hmm.
It's clearly related to a life event that's a trigger, and it's very. When you have, it says postpartum depression, but I think there's marital problems. There's probably some more major depression than just postpartum. I think that's probably the first time that somebody put her on medicine. This is just the thing about it is one of the things that we don't think about is major depression has such a focus component.
Yes.
And you can't when you're depressed like to that level, you can't focus, you can't make decisions, and that can mimic. I was getting ready to mention that earlier. That can mimic ADHD in the sense to them. It can mimic it to them. I had a patient come in the other day that wondered if he was bipolar because he had brand new symptoms of that he basically self-inflicted when we were all through talking about it. Anyway, that's my
So
spin
possibility
so
for her is that this is all secondary to depression.
Yeah.
So that's one
That's
possibility.
that's where I'm going to lead. That's where my brain's leading in. Yeah.
So how would you figure that out? How would you figure out whether this is depression or something else?
Treat the depression
Treat the
first.
depression.
Yeah.
Exactly. You could tell her, I think, these attention symptoms are a real problem, but, you're also sounding kind of depressed, and sometimes that affects your thinking, so let's get you feeling better first in terms of your depression, and then we'll take a look at your attention.
Right.
Okay, so would you continue the sertraline? Or would you do a different medicine?
I might, at this first visit, I might continue it. But she's clearly sub-therapeutic based on her symptoms, so I would consider titrating the dose or even augmenting with a second medicine that might hit some of the side effects to the sertraline or the symptoms that are not being well enough controlled.
And once again, so let's imagine she did give you a really good life history for ADHD, but she is still really depressed. That's when now maybe you want to consider bupropion. Maybe she's a good candidate for that because she does have ADHD symptoms and she's pretty depressed and the sertraline's not covering her depression. Maybe switch her over and kill three birds with one stone. Okay. How would you handle the anxiety and depression? Is there anything you do other than medicine? She's already flat out told you, I'm not going to go to a therapist because I'm already paying too much to go to this couples therapist. Is there anything else you would do or recommend to her for the anxiety and depression?
Buspar.
Right, Buspar is a good choice for anxiety in terms of minimal side effects.
I find it has a lot of side effects as far as focus, though. And I think that, I agree it's a valid option. I just don't know that it would be
The best, maybe.
And this one, who says she can't seem to concentrate, one of the number one things that my people who are taking it compliantly but still report to me is that I just feel in a fog, like I'm in a fog.
Yeah, I've had some people say that too.
Yeah.
You could go back, now remember we went back to the beginning, we talked about non-medication treatments.
Right.
You could tell her, hey, you're depressed and maybe you have ADHD, why don't you work on your sleep and your exercise for a few weeks and then come back and tell me how you feel? Because regardless of the underlying problem, that's going to help both of them.
Right.
That might be something to consider. But I think the key point here, and you brought that up, was treat the depression first and then see what you're left with. Because it's going to be very hard to tell how her attention is until you treat her depression.
Or her response. You're not responding, you're still depressed, or my dose isn't right.
So I kind of jumped ahead to some of the non-medication options. Now, we talked about kind of how the recent onset of this suggests that it's not ADHD, but you could argue the flip side of that, which is, well, maybe she had it all of her life, but now
she was coping until
now I got kid number 3, and my marriage is giving me problems, and now for the first time my symptoms are causing me problems. So that you don't want to rule it out entirely.
No, not entirely. No,
but like you
absolutely.
said, the sudden onset should make you think about other things.
Right.
Okay. One more vignette. This one's a little bit more complicated. I don't know if you get kind of this story. This is a little more complicated. You're seeing a 55-year-old man who was recently released from the hospital for pancreatitis due to chronic alcohol abuse. He's determined to stay sober. He's going to AA a few times a week. He has a substance abuse counselor that he's already gone to weekly. He has a good job with the electric company for the last 10 years, but he feels sad and frustrated because he feels he had great potential as a child, and he feels he's been a failure and let everyone down. Social history includes 3 failed marriages, college dropout, legal problems related to DUIs and bar fights. He's been drinking daily since age 15, recently thinks he's becoming addicted to opioid pain medications. During your appointment, he's emotionally very labile, crying, laughing, constantly fidgeting, shifting around in his seat. When you ask him about mental health issues, he says, when I was a kid, my teachers thought I had ADD and was hyperactive, but my parents didn't believe in all that. So does he have adult ADHD? What in the history might make you think he does?
Well, he mentions, symptoms back to childhood. mentions the impulsivity symptoms. But then, what kind of throws out a red flag that something else is going on, just how labile he is during the interview. From crying to laughing, all in the same interview, that's just really odd.
I agree.
Right.
I mean, I would be...
I wouldn't know what he has, but I'd say
at this moment,
there's something else going on. If you have ADD, there's something else going on besides just that.
You've got a comorbidity,
Right.
yeah, you do. That's exactly what I was thinking.
So say, what would you do to figure out what comorbidity might be in this guy who's kind of complicated?
I would get a urine drug screen first.
Very nice, yes.
Yeah.
Because what if huge amounts of opiates are in there? That's going to explain his, maybe his lability.
Because it sounds like, I was assuming, because he is becoming addicted to opioid pain medicine, so I'm going to assume it's already going to be in there.
So say he
Right,
got it
yeah.
because he had pancreatitis, he was in the hospital, they gave him pain meds,
Yeah.
and now he thinks he's getting hooked on them.
Yeah, but I was thinking that I want to look at illicit substances is what
That's
I'm
the number one thing
yeah.
to do, right?
concerned about.
Given the fact that he had pancreatitis and the chronic alcohol abuse, would you do lab work? Would you do more of a medical workup?
Yeah, just make sure his kidneys and his liver and everything else is functional.
Right. Because if his liver's trashed,
Mm-hmm.
he could get encephalopathic, right? And he could have cognitive problems due to his liver.
Yeah.
His pancreas is still having problems. That could give him cognitive problems. Pain meds could be giving him cognitive problems. So this is someone where your medical expertise is really important because you're going to really look carefully at the medical part. Let's say you do think he might have adult ADHD and you've done all these things. How would you get corroborated for a 55-year-old who's divorced and doesn't have any friends?
I mean,
Employer.
Good.
yeah. And then also, honestly, in this circumstance, I may have to have a certain level of comfort that I may not have a lot of cooperative. I may have to rely on it because, and it's somewhat safe for me in this vignette because I'm not going to start with an uncontrolled medication until I sort some of this mess out anyway. So to me, it really may be first part of his treatment. I may just be making an intellectual decision. Well, this guy has ADHD. I'm putting it on his problem list, and it's just going to stay there until I get a few other things sorted out. It's over there. It's real.
And I may not get corroborative ever.
And exactly, and that's what I say. And that's what I'll say. What I'll say to a patient like that is, okay, the problem's here. The problem's real. The problem is a small iron in a big fire. And right now we're going to take care of these other ones that are more life-limiting until these are.
And this may be someone that needs neuropsych testing. If you think he's got some dementia process starting,
exactly.
maybe from his alcohol use, he's got some, brain issue. Maybe he's got an early dementia starting. Maybe this is someone who does need to go out to be referred, or we can help you refer out to get some neuropsych testing.
Absolutely.
Because there may be some complications to him.
We're trying to sort out, again, though, the other pathology is really probably going to end up requiring consult anyway.
So this may be someone that you don't, going down to question number 3, would you prescribe a stimulant? If not, how would you choose a non-stimulant? So it sounds like you do the workup first.
Right.
This guy doesn't need meds walking out the door, right?
Yeah.
I'm literally saying he's not, even though I agree that his ADHD is part of the problem, it's not the first thing I'm going to treat, so.
So say you did the workup, you thought, yeah, he probably does have ADHD, I want to give him something, but I don't want to give him a stimulant. How do you choose which of these non-stimulants to give him? Let's assume his liver's okay, despite the drinking.
Based on some of the things that we've already been talking about, myself, I'm going to definitely think about some of that clonidine at bedtime anyway, because it has the use with the sudden absence of the alcohol anyway, so I consider that a kind of a bonus. But
Could treat his withdrawal. If he is having alcohol withdrawal, which hopefully he's not, but that's would be helpful.
But this is going to be one of those ones who falls in the category of, for me, a Strattera. This is going to be a great place to start with Strattera.
I would say Orientunum,
Right.
which can hit impulsivity.
Well, that's true. You make a good point there. I don't have as much experience with that one.
Okay. So I guess one question was, let's assume we think he has adult ADHD, but he's not in school, he's been at the same job for years, he's not getting fired or anything treat it with medicine? How would you decide whether to treat it?
For me, it's about the rest of his life. You know, it's about basically it is what I have to find those symptoms that are so severe that I feel like it needs a remedy.
Let's say, what would happen if you don't treat him, based on what you know about him so far? What are some things that could happen to him if you don't treat the ADHD?
He could actually fall back into some of his other patterns. I mean, you know, with the alcohol, it's going to be harder for him to stay off the alcohol because what he's going to do is going to go on a tear one day. You know, I've been good for too long. I've been, you know, I understand that notion. You know what? I have behaved just about long enough.
So he could relapse. He could
Right.
have another episode of pancreatitis.
Yeah.
He could get more hooked on the opiates. He's already starting to worry about that. So there are some consequences of not treating.
Right.
I think that was one point I wanted to bring out here too.
Yeah.
We think about the risks of treating, but we have to think about what are the risks of not treating for someone like this.
That truly.
And for him, I mean, it could send him to the hospitals, could send him to the grave. I mean, it could be quite serious.
Yeah.
So it is important to think about what's going to happen if I don't treat it.
Right. Just because they won't be able to say that you were responsible, that won't necessarily help you sleep well if it.
Right. And then finally, how do you address this issue of opiates? He says, you know, I think I'm getting hooked. He's had legitimate pain from his hospitalization, legitimate use of opiates. What would you do? Would you stop them? How would you handle this issue? He says, I think I'm getting hooked.
Goes back to harm for me. I mean, it depends on my level of comfort, but can this person make a promise and be able to stay within the promise? You know, if it, you know, there are people, I call it to a certain degree called chemical coping. There are certain people who probably, you know, is their pathology, does it explain the amount of opioids that they're using? Not maybe 100% completely, but they take it exactly as prescribed. They're good with their follow-up appointments. They're safer than doing what I'm not finding evidence that are supplementing with stuff on the street because of my panels. Mm-hmm. And so, I mean, that would be the key point that I would have to answer for myself is this someone I could use harm reduction therapy and manage it? Or are they going to, no matter what promise they make, are they going to continue to supplement in other ways? And then, you know, that removes me from, then I have to do the best I can to manage their pain without the tool of an opioid.
Would he just be receiving pain management from us? But if he's receiving pain management services from someone else, kind of want to communicate that to the other provider instead of just stopping someone else's medication.
Sure.
I'm going to go on the phone and say,
absolutely.
Situations of
Absolutely.
So kind of these are the issues that come with all your pain management patients too, and they're not different for him. You have the same thoughts with him, even though he's got the history of alcohol abuse already. I think you're wise to consider him like your other pain management patients, and not just say, "Oh, you had an alcohol problem.
You're done." Right?
You're done.
No. Yeah.
Think of him in the same way you think about your other patients. I think is wise, but realizing he may be more impulsive.
Exactly, and
than other patients.
Absolutely. And for that reason, he may not be able to successfully keep a promise like that, and that's how I have to stratify it. Do I feel like he's someone that can operate within parameters?
This was all I had prepared, but these are great questions. What are some other things as we're talking that are coming to you? Any other cases or questions you're thinking of?
Specific to ADHD or?
Just in general, yeah. Is there anything this is triggering any thoughts that?
Yeah,
so
there you go.
I mean, resources to do neuropsych testing.
Okay. So your choices are going to be to do a computer test or to do a neuropsych test. So neuropsych testing is done by a specialized psychologist. And Chad, this would be a role that we would help at. We could help you find a resource for that. It is long. It's kind of considered the gold standard. It's long. It's expensive. I don't know if Medicaid is paying how they're handling that. Normally they do cover it.
Yeah.
But there may be a little bit of a wait. Now the computer tests are not considered as much the gold standard, but they're a lot easier to use. So there's different ones out there. I mentioned two of them here, continuous performance test and the attention network test. Continuous performance test, there's a software that you can purchase, and I don't have all the pricing information, but that might be something to look at.
Okay.
The nice thing about the computer test, you could, I mean, I know you're tight on space probably, but if you have a little space somewhere, you could stick a little computer in there and a chair. You can do it on site, and you can bill for it.
Now, so the test is not off of a website or something, it's software that you actually purchase.
Well, so there's the attention network test. Now that's one that is freely available. The version that's freely available online doesn't have an interpretation section, so you'd have to work with someone to interpret it. Or if you're interested for your practice, I have a version that you could beta test that does have some interpretation. It's not in the formal release yet, but that's something that if you guys wanted to beta test here, you could do that. It would be free. The continuous performance test, I think it's not web-based. I think it's still a download software.
Okay.
There's another one called, I think I put in here, Sienna's Vital Signs. A group out of Chapel Hill designed that one. That is web-based.
Okay.
And I think they bill you as a practice like $100 for it or something like that, and then you can give it to your patients anytime.
So it's a one-time. It's not $100 per time the test is administered. It's a.
You can get packages for like a number of tests at a certain price, or a one test fee, and then you as a practice can bill to the insurance the test taking with interpretation.
Okay.
And again, I'm not sure what the reimbursable rates are for that. They're probably pretty good though. I don't know, maybe $100 or something.
And Dr. Shea, just to interject on that, if that's something you're interested in, we might be able to write a QI grant.
Okay.
Especially if we could tie it to one of our performance measures.
All right.
And then if you do have that computer test and some of these patients where you can't get corroborative or you really want that quantitative number, the test can help show you how they do before and after medicine. So you should see improvement on the test with medicine, which is one of the best ways to use the test. Not diagnostically, but to see how the medication.
Therapeutically.
Yeah. So it can be really, especially if you're not sure whether to go up on dose or not. If you do the test and they've completely normalized on their score of attention, you might say, well, you might want to do some other stuff because you already seem like you're doing pretty well.
Mountain Dew at the right moment of the day.
But that's a great idea. Maybe we could think about some different ways, or the beta testing, or both. You know, you could do a little comparison study. But that's a good test to have. It's not diagnostic in of itself, but it's a good complement, especially for some of the patients you're not sure about. Any other thoughts in terms of what we could do practice-wise to...
I think you hit some of the bigger ones, working with Chad and our behavioral health folks on referrals and things like that. And then the grant opportunity just went straight up whenever she mentioned the cost with the software. So.
And we could do ratings. We could help you pick a rating scale to use. The key in the rating scales is not the rating scale, right? It's like who's going to give it, who's going to rate it, how are you going to read it, who's going to be in charge of, like, it's logistics around the rating scales that get messy. But that's another thing maybe. Some of them are free, some of them have a nominal cost, like you buy a workbook and then you can use it indefinitely. So that's a pretty nominal cost, but logistically you have to kind of figure out how you're going to use it.
Another thing too, earlier talking about ADHD patients being the ones who often are the forgetful and they might get their med billed at some strange schedule. That's not exactly what you intended because they forget, they don't have their script, that kind of thing. CSRS, you mentioned, I know you guys already use that, but also Provider Portal on our Medicaid system has no claims data for services, but it has medication data. So that might be another sort of checkpoint of frequency of fills and things like that, if that helped at all.
In the controlled substances database, you can
I guess
check
that would
too.
pretty much have.
For the stimulants.
Same.
Now the non-stimulants, you can
Okay.
check the other system and see that too.
Okay.
Good. Well, thank you so much.
you
It's
very
been a
much.
great conversation.